day. May I introduce Dr. Divyamol. Her present appointment is Assistant Professor, Department of Geriatrics, Amrita Institute of Medical Science and Research Center, Kochi. And she is an MD Geriatrics, a National Fellowship in Palliative Medicine, and her work experience is commendable. She's worked as a consultant in various positions in Goa and also at Amrita Health Center, Port Blair. And presently, her areas of interest, she's also the president of the Indian Academy of Geriatrics, Kerala chapter, and the areas of interest, upgrading geriatric assessment, care skills of medical, paramedical workforce, our community volunteers, and also comprehensive geriatric assessment, fall risk assessment, dementia, and palliative care in geriatrics. So welcome to this evening, Dr. Divya, and over to you.
I'll share my slide.
Yes, screen share പറ്റുന്നില്ലേ?
But no.
Divya,
Is my slide visible?
yes, ഇപ്പൊ വന്നു, yes.
No. Okay.
Slides.
Slideshow?
Yeah, done.
Okay.
So Divya, you can start. So this is a meeting that's been going on for almost 9 months. Every month we are able to meet regularly. And Geeta Madam പറഞ്ഞ പോലെ Divya is an apt person in the right time. ഞാനിത് ദിവ്യയിലൂടെ ഏകദേശം എനിക്ക് തോന്നുന്നു 5-8
I
വർഷമായി.
forgot to mention one of the most important points in, sorry, Dr. Atul, because she's also in charge of domiciliary care at Amrita Hospital.
Amrita recent home care systemത്തിന്റെ charge ആണ്. And Divya is interested in palliative care since I've known her since 2016. So it's an honor to invite Divya to this meeting so you can take charge here.
The volume is quite low. ഞങ്ങള് സത്യം പറഞ്ഞ geriatric populationന്റെ ഒരു നല്ല representation ഇതിന്റെ ഉള്ളിലുണ്ട് ഡോക്ടർ ദിവ്യ. So please, if you can increase the volume. I can't hear.
1 second. Am I audible now?
If you can make it a little more.
Let me just see. Volume full ആണല്ലോ ma'am. Volume full ആണ്.
Okay, fine. Maybe I don't know if this thing is.
ദിവ്യയുടെ കുറച്ച് കുറവാണ്. അതൊന്ന് ദിവ്യ ലാപ്ടോപ്പിന്റെ അടുത്തോട്ട് കുറച്ച് നിന്നിട്ട് സംസാരിച്ചാൽ മതി.
Okay.
ദിവ്യ ലാപ്ടോപ്പിന്റെ അടുത്തോട്ട് കുറച്ച് വന്നിട്ട് സംസാരിച്ചാൽ മതി. I think ലാപ്ടോപ്പിന്റെ
ഞാനാണോ വെക്കേണ്ടത് അതോ ഡോക്ടർ ദിവ്യ?
ഡോക്ടർ ദിവ്യ. ഡോക്ടർ ദിവ്യന്റെ മൈക്കാണ് കൂടുതൽ അടുത്തോട്ടുണ്ട്.
എന്റെ മൈക്ക് ഞാൻ ഓഫ് ചെയ്യണ്ടേ?
Yes ma'am.
Yeah.
ഇപ്പം കേൾക്കാമോ?
കേൾക്കാം. പറഞ്ഞോ. You can start, Divya.
Okay. So today I will be speaking to you all on basic comprehensive geriatric assessment. So I believe we are all doctors here, and we are all doctors who are actually seeing a lot of geriatric population. So I believe it's very important for us to know the basic comprehensive geriatric assessment. So after my class, we should be able to define comprehensive geriatric assessment. We should be able to identify who all needs a comprehensive geriatric assessment, the benefits of the comprehensive geriatric assessment, what are the various dimensions of comprehensive geriatrics assessment, and what are the common tools that we are using. That will be the basic of today's class. So what we see is that when an elderly person presents to the OPD, they might OPD or even in a home care or whenever you are called for an advice, usually their main presenting symptoms may just be fever or a urinary tract infection or an abdominal pain. But usually that is just the tip of the iceberg. Usually there's a lot of issues that is underlying which might be predisposing this person to that condition, or which might actually worsen the patient's overall functional status with even a minor stressor. So it's always important as a doctor to identify what all lies underneath the iceberg as well. So when you come to comprehensive geriatric assessment, what do you mean by comprehensive? Can somebody tell me? Nobody? Okay. Okay,
Something that makes sense. Yeah.
yes. So it means extensive or broad or complete. Basically, we want to see the person as a whole. I think that is the basic of palliative care as well as geriatric care. That is somewhere where we are very much on the same page. Geriatric in India, it means people who are above 60 years of age. And internationally, we are talking about people who are 65 years and above. Assessment means it's not something that the patient says alone. It's also what you are observing, what you are assessing, and your perception also matters in the assessment. So, comprehensive geriatric assessment is a systematic, multidisciplinary evaluation of a frail older person. Now, each and every word is important. It is multidisciplinary, it is systematic, you go step by step. Also, it is for frail older persons. Comprehensive geriatric assessment is not something you do for everybody who is old. It is for the frail older people. So, the physical, mental health, the functional status, social, and also the environmental factors are evaluated in comprehensive geriatric assessment. After the assessment, you make your recommendation and plan the interventions. That is how we go about with the comprehensive geriatric assessment. So, basically, comprehensive geriatric assessment is like a full body checkup for elderly with special focus on retaining the function and improving the quality of life. So, who all needs comprehensive geriatric assessment? Usually, frail elderly who are above 75 years, they definitely need a comprehensive geriatric assessment. Any elderly who is having multiple comorbidities or with polypharmacy, they definitely need a comprehensive geriatric assessment. People who have a recent onset functional decline, that is, if the patient was okay till, like, let's say last week or 2 weeks back, then suddenly they have become bedbound, or they have stopped eating food, or anything has happened in their recent functional ability, then yeah, it should ring a bell. Maybe it is something that is correctable. Depressive symptoms, this is very common in elderly. So about 45 to 50% of elderly have depression. Geriatric depression is that common. But so if they have depressive symptoms, again, you have to dig into what all are the causative factors for this to see what all can be corrected. If any patient is having history of falls, many a times, unless the fall is that significant to cause a fracture or to cause okay, so unless a fall is that significant to cause some fracture or else a cut or else a um, some injury happens, otherwise they usually don't report the fall. So it's always very important to ask for a history of falls to any elderly that you're seeing. And accordingly, if they have history of falls, definitely they need a comprehensive geriatric assessment. Also, urinary incontinence, fecal incontinence, these are things that people are not very open about. So we have to ask for the history, and if it is there, definitely go ahead with a comprehensive geriatric assessment. Also, patients with cognitive decline, and also patients who have had more than 2 admissions in a year to a hospital, maybe there is something that also needs to be addressed, something that is going missing. Or if anybody is needing help with their routine activities, also they may benefit from a comprehensive geriatric assessment. So, what is it when you are seeing an adult patient? You will be taking the history followed by a physical examination. But when you are seeing a geriatric patient, there should be history, physical examination, followed by a comprehensive geriatric assessment. So, this is the extra thing that you have to do for all elderly patients. So, basically, a comprehensive geriatric assessment, it prevents or delays patients from becoming homebound or dependent. That is, if we can identify the factors, like there are factors like fear of fall, maybe recurrent urinary infection, constipation, maybe fecal incontinence, all such things that are usually not um, thought to be significant, which might be the causative factor for that functional decline. So, if we are able to identify that, correct that, sometimes visual impairment, hearing impairment. So, such things, when you correct it, the patient becomes more active, they become more, they get a better quality of life. Also, this enhances the health and functional outcomes of the patient, reduces readmissions to hospitals. If you see patients who are, most of the patients at least, who are having repeated admissions or repeated urinary tract infections, you will see they have constipation as always a background issue, which is never addressed. So, many a times when you address that issue, even the recurrent UTI, the frequency comes down. It also helps in better management of geriatric symptoms like urinary incontinence, falls, dementia. Falls also, like many a times a patient presents with a fracture, the fracture is fixed and patient is sent back without a falls assessment. Why did the patient fall in the first place? Was it a hyponatremia? Was it a syncope? Was it a postural hypotension? Nothing is usually looked into. So definitely such things have to be looked into in such situations. So, when we come to the dimensions of CGA, we are looking at the physical health of the patient, the functional status of the patient. We have to screen for geriatric syndromes, look at the nutritional status of the patient, do a detailed drug review for the patient, and also look at social and environmental factors. Now, coming to each. So, in the comprehensive geriatric assessment, we will be involving all this like vision screening, hearing screening, frailty screening, fall screening, depression screening. Uh, all this, including vaccinations, will come as part of your geriatric assessment. And when it comes to vision screening, you can, it's not always practical to go with all this, tools or with the Snellen's chart all the time. So you can ask them, are they able to read well? Do they have any visual problems? Such simple questions might also help you screen for visual problems. The most common visual problems that you face in elderly are cataract, macular degeneration, retinopathy, glaucoma, presbyopia, and so on. But many of these problems are correctable. Also, screening for such problems, like if it is a patient who is having diabetes for a long time, definitely a yearly screening for a diabetic retinopathy should be advised. Screening for hypertensive retinopathy should be advised. Many a times the common people, they do not know about that screening is important. So, so Vishen, you can ask, do you have difficulty watching TV, reading, driving, or do you have difficulty in doing any of your daily activities? And if it's a yes, then definitely you can uh, get them for a detailed vision screening. Otherwise, you can use a Snellen's chart as well. And visual impairment has been found to be leading to increased risks of fall, functional and cognitive decline, immobility, and also depression in elderly. Then coming to hearing impairment, again, hearing impairment is very prone to even cause dementia in elderly, and also it leads to social isolation. So it's very important to identify this and address it. So to test for hearing, you can ask them, do they have any difficulty to hear? Otherwise, you can do a yeah, this I've already said. And then coming to the memory impairment. Now, dementia, um, it's the incidence of dementia is rising every year, and also dementia awareness is also rising. But the fact is, many of us, as in, we are not having to use our memory or our brain as much as we used to use earlier. So the um, number of dementia cases are also increasing day by day. So to test for memory impairment, we can do a simple mini cog test, which is a 3-word registration, clock drawing, and followed by 3-word recall. Now, 3-word registration means you can tell any 3 words, 3 words which are not related. You cannot say pen, pencil, paper. You should say things that are totally unrelated to each other. Like, let's say, pen, apple, chair. It can be a curtain, pen, um, flower, things like that, which are totally not related. And do not use very complicated words, because it should be simple words which are easy for the patient to remember. After that, you can ask them to draw a clock. Drawing the circle usually does not have any mark, but correct numbering, that is 1 to 12, they should write the numbers in the correct order. That gives them 1 mark. And then finally, drawing the clock, the arrows or the hands of the clock, gives them the 2nd mark. So if they get this 2 marks, they get 2 marks. After this, registering the 3 words does not give them any points, but remembering the 3 words will give them points. So if a patient has 3 out of 5, then you can 3 out of 5 or above, you consider that the patient is not demented. But 3 or below, you consider it as patient may have cognitive impairment, and patient will need more definitive testing for cognitive impairment. So other than this, we have also GP-COG, we have MMSC, which are like more detailed tests to test for memory impairment. Then coming to the functional status. When you come to the functional status in elderly, you have the basic activities of daily living, you have instrumental activities of daily living, and you have advanced activities of daily living. Basic activities of daily living includes like simple things like eating, bathing, dressing, walking, basic transferring, toileting. All these are considered as your basic activities of daily living. Usually, if a patient is dependent on basic activities of daily living, they're definitely dependent on instrumental activities and advanced activities of daily living. Instrumental activities of daily living are a higher level of activities, whereby they are talking about shopping, cooking, making phone calls, managing money, managing their medications, and so on. So we have scales for this to actually calculate how dependent they are. But basically, the more dependent they are, the more the lower their functional status is in both basic and instrumental activities of daily living. Advanced activities of daily living means patient is functional even in their society roles. They are able to attend functions, they are able to fulfill their role as a parent or as a grandfather or as an advisor. All those societal roles, if they are able to fulfill, you consider that they are active in their advanced activities of daily living. Then we come to frailty. Now, frailty is actually a syndrome. So it is a syndrome which comprises of weakness, generalized weakness. Patient feels very weak. They have weight loss, which is unexplained. They might have a lot of exhaustion. They always feel very weak. They want to lie down, and they have very low performance uh, in their day-to-day activities. So many factors contribute to frailty in elderly, such as aging, which is not modifiable. Genetics are not modifiable. But however, lifestyle, environment, and multiple diseases which might be contributing to the frailty are the modifiable risk factors of frailty. So all this causes chronic inflammation, which results in changes in your muscle, endocrine system, hematological system, even in your heart. And the outcomes of this frailty is patient may have multiple falls, they become dependent, they become more at risk for surgery or even death. Usually a frail patient has a worse prognosis to any condition compared to a robust elderly person. So to check if a patient is frail, you can look at this 5 criteria. That is, if there is unintentional weight loss or loss of muscle mass, or if there is a 10% loss in their body weight over the past 6 months, which is not explained, that is considered as one factor. Weakness, that is usually checked with the grip strength. Exhaustion, it's usually self-reported exhaustion. They feel weak most of the time. If they're not able to walk fast, like you can do a uh, timed up and go test and you can see how fast they're able to walk. So that can also give you an idea on the frailty. Also, they have very low activity and generalized, very reduced activity in their day-to-day life. All this should point towards frailty. We can also use a clinical frailty score, which is most commonly used, whereby on seeing the patient, you can assess and you can find out whether this is a patient who is mildly frail, moderately frail, or severely frail. Now, next we come to urinary incontinence. These are all the geriatric syndromes that we are talking about now. So it's usually underdiagnosed because many people do not complain of it unless you ask them. Many of them of aging, which it is not. So we have incontinence questionnaires to actually ask for the thing, but usually we ask them, have you had any leaking of urine in the past 3 weeks or 2 weeks? Past 1 month is what I usually ask. And once that question comes, they'll open up. Similarly, you can ask about their bowel habits. Do they have constipation? Do they have incontinence? Do they have diarrhea? Sometimes they have a lot of both constipation followed by diarrhea. That is also very common. So asking about these histories are very important. Falls is again a very important problem in the elderly. And usually a person to fall, they should have, as in everybody has their own reflexes to prevent falls. But with aging, what happens is that their reflexes to prevent this fall comes down. Along with that, when there are medical conditions like maybe incontinence, dementia, or any medications like benzodiazepines, or even for that case, sometimes even cetirizine causes that dizziness, which can predispose an elderly to falls. Even depression, living alone, all the inactivity, if they are having, all this can predispose a person to falls. And along with that, when they have impaired vision or any sensory difficulty, they are having numbness or paresthesias, they're not able to feel the ground, then this makes a patient more vulnerable to falls. And along with that, if there are even environmental hazards like maybe a slippery floor or a poor footwear, this will again predispose the patient to fall, and the patient keeps falling. So many of these factors can be modified or corrected. So it's very important to find out whether the patient has been having falls or not. if so a very simple bedside test to do is a timed up and go test. This is a test whereby you make a patient sit in a chair, usually a chair with the handle. So you make the patient sit comfortably, and they can use any of their assistive devices if they're using, and they're asked to walk 3 meters, that is about 10 feet, at their normal pace with their usual assistive devices, then turn and then return to the chair and sit down. Usually, a normal adult or normal person should be able to take less than 12 seconds. Normal is 8 to 10 seconds. So, up to 12 seconds, they might take, it is fine. If they take more than 15 seconds, there is a high risk for fall. And if they take more than 30 seconds, then they definitely need assistance because they are definitely bound to fall. So that is how you use the timed up and go test. You can do it anywhere. So it's a very handy test that you can use. And timed up and go test not only assesses the fall risk, it also assesses the frailty level of the patient. So thereby, it's a very, very important test that you can use. So this is the test that I said. So from the time the patient gets up to the point where the patient sits back on the chair is what you're timing. So now we'll come to a case. There's an 80-year-old male who presented to OPD with intermittent headache since 3 months. He was shown to outside hospital. CT brain was normal. He was prescribed some analgesics. Symptoms are persisting. And his comorbidity is only hypertension. Physical examination is also very normal. What could the reason be? Anybody? Any differential diagnosis?
Any vision disturbance?
Okay, that is one. Another? Anyone else?
Vascular headache?
Yes. Yeah, that is also possible.
Is it because of sleep
Rule out
disturbances in sleep?
Huh?
Rule out
Disturbance in sleep.
Rule out?
hypoglycemia.
Okay. But patient is not a diabetic.
Temporal artery.
Dehydration.
Dehydration can cause, yes.
Vision.
Vision, yes, somebody has already said
Hello?
vision.
Hello, Hello.
But this old man had, when we did a comprehensive geriatric assessment, he had a geriatric depression scale of 3/4. So this patient was actually having a tension headache, or because of the depression, the patient was always having this headache. Once the depression got addressed, the patient's symptoms drastically improved. So usually depression is undiagnosed in elderly, and it's associated with disability, morbidity, higher suicide rates. And usually what happens is that the patient presents with multiple somatic complaints. It may not just be headache, it might be generalized body pains, it might be feeling lethargic, they might have multiple issues. They might even say that they're not depressed, but when you actually ask the scale, you will actually get a good depression score also. So it's always very important to screen for depression in the elderly. So this is the GDS-4 that was used in this patient. That is, are you basically satisfied with your life? Do you feel that your life is empty? Are you afraid that something bad is going to happen to you? Do you feel happy most of the time? So this patient had 3, so patient was considered as depressed. After this, we don't, in geriatrics, we don't stop at this. If they screen positive, we go for a more definitive testing. But it's a good screening tool. There are also simpler tools like PHQ2, where you just ask, over the last 2 weeks, have you had little interest or little pleasure in doing things that you used to previously enjoy? Or are you feeling down? depressed or hopeless most of the days. So even this is just a 2-question screening whereby it can hint towards depression in the elderly. Next, we'll come to drug review or polypharmacy. Polypharmacy is the use of 5 or more drugs in elderly. So many a times, elderly patients, they have multiple comorbidities. So they will be on multiple medicines. So there is something called as essential polypharmacy and non-essential polypharmacy. Essential polypharmacy is whereby all these medicines are very essential for that patient. Whereas non-essential, there might be multiple supplements, there might be duplication of drugs, there might be some medicines that are not that essential, you can get away with it. So such use of so many such drugs is the actual polypharmacy we are talking about here. Now, polypharmacy leads to increased adverse drug events, drug-drug interactions, more as in if you're giving 3 drugs with anticholinergic effects, all these anticholinergic effects will add on, and finally the patient will have intolerance to the drugs. So such things are very common in elderly. So using drugs very appropriately is very important in the elderly. So drug-drug interactions can occur. It can lead to increased risk of fall. And also many times what you see is when a patient has so many medicines, they're not sure which is the most important one, which is the one that they can, just maybe if I don't feel like I can, not take this medicine. So sometimes they do not take what is essential and take the supplements, which maybe are not that important. So things like that happens because of the polypharmacy. So always a brown bag review is very important. By brown bag review, what I mean is you have to see the patient's medicines, not just the prescription. There might be multiple prescriptions, but the easiest way to do a brown bag review is to ask the patient, have you brought your medicines? Can I see the medicines that you're taking? And you see the medicines as such. Sometimes the dose may be different, sometimes the drug itself may be different. So all that you have to screen by yourself and correlate it with the prescriptions that has been given to the patient. So now here is a patient, 86-year-old female, who presented with complaints of dryness of mouth since 6 months. So comorbidities were diabetes, hypertension, vertigo, and physical examination were normal, but the patient complained of dryness of mouth. So here again, what all would we think about? Anybody?
Patients are on any anticholinergics.
Yes, that's a very good thought because we are actually talking about polypharmacy. So definitely dryness of mouth could be because of polypharmacy or anticholinergic effects of a drug. Otherwise, any other difference?
Anxiety.
Yes, anxiety can cause anything else?
Diabetes can cause diabetes.
Exactly. Even uncontrolled diabetes can cause.
Uncontrolled dehydration.
Dehydration.
Yes. So this patient, when we saw the medicines, the patient was taking metformin, dapagliflozin, cilnidipine, telmisartan, and sometimes levocetirizine, which was something that she was taking over the counter. It was not something that was there in her prescriptions either. So this was causing the anticholinergic side effect, leading to the dryness of mouth. So getting rid of this itself got rid of her problem. When you see drugs that have anticholinergic side effects, you'll be surprised that almost most of the drugs that we usually use have anticholinergic side effects. So it does not mean that we should not prescribe these drugs to elderly, but we should keep an eye that are the side effects bothering them. If so, we might have to adjust the dose of this medicine. So we need to know that such a medicine has anticholinergic effects, and usually for elderly, some of them they have very high discomfort because of such medicines. Now coming to another case, 69-year-old female came for a routine checkup, known case of hypertension. Patient was on Telma 40 and hydrochlorothiazide for 4 years, and dyslipidemia on atorvas, hyperuricemia. Now she has been started on tab febuxostat for 6 months. Any idea what has happened? Are all these medicines needed in this patient?
Maybe thiazide causing hyperuricemia.
Yes.
The patient might have hyponatremia.
What? No, patient came for a routine checkup. There's no hyponatremia. Just that patient had hypertension. Then she was on Telma H and dyslipidemia. Now patient has been diagnosed with hyperuricemia and we have started tabfebuxostat. Is this the correct way to treat the patient?
The pujari there, the priest.
Anyone?
And he said, you are going to be extremely intelligent. So intelligent, it's a very, very unusual horoscope, it seems.
Is that who is? Hello? Okay. So now this is, I think somebody had answered first that the thiazide can cause hyperuricemia, and that is what you call a prescription cascade. So ideally for hypertension, you gave a thiazide and that caused hyperuricemia. The step that should have been taken was remove the thiazide, adjust the antihypertensive and move on. But here what happened is that you have actually added another drug. So this is in turn leading to polypharmacy in the patient. So you give one drug, a new medical condition comes, a new drug treatment is given, and then this will lead to another medical condition. So this is usually what you call as a prescribing cascade. Anybody can give me an example of another prescribing cascade, which is very common? Anything in your experience?
AC inhibitors can cause cough,
Yes.
and for that cough medication will be given.
And that will cause? Even
That's
antidepressive, then again, that will cause constipation and it
okay.
will lead to more discomfort. One thing I usually see is when a patient is on amlodipine or cilnidipine, they develop pedal edema and they will be given Lasix or lacilactone. Then they end up developing hyponatremia. So it's all prescribing cascades are very common. So it's very important so that any symptom that the patient may present with, always look at the drugs. Is there anything that can cause this? If so, modify that. Next, we come to nutrition. Now, loss of appetite, loss of weight, all that are not normal part of aging. So if a patient is having loss of appetite, loss of weight, we definitely need to evaluate. And in elderly, it's not always that loss of appetite, loss of weight is due to a cancer. Definitely, we will be thinking of malignancy. But before that, there might be even modifiable factors such as poor dentition, sometimes it's because of environmental factors like they're not getting food, they're not able to make their food, there is no caregiver available. Sometimes it might be even constipation, they're always feeling that bloated and nauseous and they do not feel like eating because they have no appetite because of constipation. So many times loss of appetite, loss of weight, before we jump into all the fancy investigations, needs a detailed examination and evaluation of the nutrition of the patient. So we have to do an orodental examination to see whether there are recurrent oral ulcers or any ill-fitting dentures, or do they have poor teeth, poor teeth, poor hygiene? Is there anything like that which can be addressed before it actually leads the patient to malnutrition? So if we're seeing loose teeth or poor teeth, always discuss regarding maybe we should address it before it causes issues for the patient. We can use a mini nutritional assessment scale, but again, this is a scale that can be used, and many times it's used. But even asking about their nutrition, what did they eat, how balanced is their diet, such questions might also help you to actually identify whether their nutrition is adequate or not. Then coming to sleep, how many hours of sleep does an old person need? Anybody? Is 4 hours enough? 6 hours enough? 8 hours?
6 to 8 hours.
6 to 8 hours, yes. Even yeah, even if some people believe that as you grow old, your sleep uh, time reduces. So even if they're sleeping 3-4 hours, they feel it's because of their age, which is not so. Even an older person needs to sleep for at least 6 to 8 hours, preferably 8 hours. And if they do not sleep that well at night, it leads to increased fatigue, more chances of falls, daytime sleep, the reversal of their sleep wake cycle, and overall reduction in their functional status. So, sleep is very important in the elderly. Also, you have to see if there are medications that affect their sleep. Sometimes you have patients who are taking Telma H twice a day. So if they're taking a diuretic at night, they will have increased urinary frequency that might be stopping them from sleeping well. There might be people who are taking steroid tablets at night. It should not be taken at night. It is something that causes insomnia. Also, there's a very common combination or a very common drug that is given for depression, like escitalopram. Escitalopram is a drug that causes insomnia. So that is a drug that if you're prescribing should be ideally prescribed in the morning time. But many times you see that you have the escitalopram plus clonazepam combination, which is given at night. So one drug causes the insomnia and the other drug helps you to sleep. So thereby that is leading to polypharmacy. So instead, if a patient is having depression and insomnia, it is better to give a drug such as mirtazapine, whereby the antidepressant and the sleep inducing effects are both present in the same drug. Sometimes these patients might be having REM sleep disorder, or they might be having obstructive sleep apnea. So definitely sleep, if it is not adequate, it needs evaluation. Sometimes it's very simple problems like sleep hygiene may be the issue. So addressing that. Anyone? Any questions?
നമ്മള് ചെയ്യണത് തന്നെയാ ഇത് എന്തിപ്പോ ഞങ്ങള് വലിയ റെക്കോർഡൊന്നും വെക്കുന്നില്ലെന്നേ ഉള്ളൂ ഞാൻ.
കാര്യങ്ങൾ പോഡ്കാസ്റ്റ് ആയിട്ട് റെക്കോർഡ് ചെയ്ത് വെക്കും. ഇതൊക്കെ പറഞ്ഞാൽ ഒന്നും കേൾക്കില്ല.
Dr. Anandam?
Studio.
Dr. Anandam?
ആക്ച്വലി മറ്റു സാധനം ചെയ്താൽ മതി അമ്മയെ കൊണ്ട്. ഇനി എന്താ അറിയോ, ഇനി ഇൻസ്റ്റഗ്രാമില് അങ്ങനത്തെ ലൈഫ് സ്റ്റൈൽ സാധനങ്ങൾ വയസ്സായാലും അങ്ങനെയൊക്കെ ശ്രദ്ധിക്കണം. അങ്ങനത്തെ സാധനങ്ങൾ ഇൻസ്റ്റാഗ്രാമിൽ റീലാക്കി ഇടാം.
മ്യൂട്ട് ചെയ്യാൻ പറ്റില്ലേ?
മ്യൂട്ട് ആക്കി. Yes. Okay. So we have a sleep quality questionnaires which can be used to assess the sleep in the patient. But otherwise, generally asking itself, actually, most of these things, if you are at least, if you know all this matters, and if you make a point to ask all this itself, it will give you a lot of information to actually make the life of that elderly much better. Then you have to also consider the social and environmental factors in the patient, like who is there in the family, are they living abroad, most of the time are they living alone, most of the time their kids nowadays are living abroad, so the elderly might be living alone. Sometimes there might be caregiver burden, the elderly lady might be taking care of a demented husband, so things like that might be an issue. So always find out who is their family, who is the caregiver, what is the social support they have, what is the economic status of the patient. This is very important for even prescribing any drug, including a vitamin. When you write, you should be very careful whether the patient can afford it. Do they have any insurance to cover for their health care? How is their physical activity during the day? There are a lot of people who gradually just withdraw to themselves. They spend most of the days lying down or just sitting because there's nothing to do. So such things needs to be addressed early so that they do not go into the functional decline or sarcopenic state. Also look at especially when you go for a domiciliary care, or when you're going to somebody's home, always assess the lightings in the house. How are there railings? Is the house elder friendly? How are the toilets for the patient? Is there any crowding of furniture in the house? Are there loose toys, or cluttering, or um, rags lying down on the floor, which can predispose the patient to fall? So such things, always keep your observation skill very keen, so that in case there is anything, you can alert the family before the fall actually happens. Also, we have to ask about the vaccination status of the patient. So we have the main 4 vaccines which are routinely prescribed are pneumococcal vaccine. Here we use PCV13, followed by PPSV23 after 1 year. Then the booster comes every 5 years. Influenza vaccine is advised to be taken every yearly. And herpes zoster, we have the Shingrix vaccine, which is usually taken at zero dose, followed by between the 2nd to 6th month they can take a booster, and then that gives them their lifelong immunity for herpes. And tetanus, every 10 years they should be advised to take a tetanus vaccine as well. So you should always check also whether their vaccination status is up to date. Now, many times what happens is that usually if a patient comes to you with a problem, like let's say a patient who is coming with a known case of diabetes, coming with neuropathy and coronary artery disease, patient comes with numbness and burning sensation in the feet. We'll diagnose the patient with diabetic neuropathy. We will give a pregabalin and send the patient home. That is what we usually do. But then after a comprehensive geriatric assessment, maybe you have seen the list of medications the patient has. Maybe you have detected that no, this patient is having already on pregabalin NT. NT may predispose the patient to fall, nortriptyline and all. It's not advisable in the elderly. You might want to come down on that medicine. Also, you might want to check for the fall risk assessment of the patient. Are these drugs safe in the patient or not? A patient is taking 2 types of multivitamins. That is not needed. You can cut it down to 1, or even decide whether that 1 is actually needed or not. So such things are things that you can actually find out from a comprehensive geriatric assessment. And if actually you do a proper cognitive comprehensive geriatric assessment, you might find that what you had initially found out, that diabetic neuropathy and coronary artery disease and hypertension are just one of the problems. But other than that, they might be having postural hypertension, they might be having constipation, geriatric depression, insomnia, inappropriate medications, frailty, fear of fall. All these problems might come in if you actually see the patient as a whole. So as a take-home message, I want to tell you all that comprehensive geriatric assessment should be part and parcel of geriatric assessment of elderly who are at risk, not the very robust elderly who are very active in their advanced activities of daily living. But if they have deficits, if they are dependent, let's say for shopping, or let's say for if they are dependent on the instrumental activities of daily living, you should find out why are they dependent. Is it something that is correctable? It is usually a multidisciplinary process. So you might need a physiotherapist, you might need a nurse, you might need a psychologist, sometimes you need a dentist, you might need different specialties of doctors to intervene to actually improve the quality of life of that person. But do it if that makes a difference for that person, definitely do it, because being bedbound or being dependent on somebody is considered as the worst nightmare when it comes to an elderly patient. So everybody, I have not really had many patients who are scared to die. They're actually scared they will become dependent on somebody, they will be burdening somebody. So it is our duty to identify the patients who are pre-frail, because if the patient is too frail, there is no point in doing any of this. They have become too frail, then only supportive management helps them. If the patient is too frail and we go ahead with the surgery, very high chances of adverse outcomes, or uh, the chances that the surgery may fail. Similarly, for anything as in advanced testing and all that in very frail patients does not warrant any benefit to the patient or to you. But if it is in this pre-frail group, then it can make a lot of difference. So identifying them is very, very important. So and involve caregiver or the family member in each and every part, so that they know why this assessment is needed, why rehabilitation is needed. Because always it should not be that, oh, they're that old, so it is okay, let's just give them supportive care. No, wherever there can be if there is a scope for rehabilitation, always rehabilitate an elderly person. That is the main take home message that I want to give you all. Any questions? Any questions?
I want to know if there is a role of bisphosphonates in osteoporosis, which may lead to fall and fracture later on.
If a patient is having a history of falls, definitely the patient should be screened for osteoporosis. And if there is osteoporosis, definitely bisphosphonates have a very good role. But it does not have a role in high intensity falls. So it's in the low intensity falls, and to improve the bone strength, that this bisphosphonates help. Or also you have anabolic agents like teriparatide and all that also, which helps. But first first and foremost for falls is to finding out the cause of falls, and also the other preventive measures like railing and all those things also have to be done. And also to make the patient more resistant to the complications of falls, definitely bisphosphonates should be used. Did I answer your question, ma'am? Any other questions?
Yes. Do you advise the caregivers to go for surgery in case of fracture femur? Usually that is the very common one that we come across. I've had many cases where I have suggested surgery and the other departments would say, no, they are not fit for surgery. But I think, like what you just now showed us, the goal is not to add years to your life, but to add life to your years. I think they should go for surgery. And even if they die on the table, that is not a loss.
But then the problem is that many times the surgeons may not opt for surgery, because if the patient is too frail, they won't take that risk. Because although as palliative care we feel that okay, even if they die on the table it is fine, for when it comes to the family and the surgeons, they may not really take that risk. So in such cases, if they are very frail, yeah, then we usually go for conservative management. But if there is any way that even in high risk surgery is possible, then we always opt for surgery. Nowadays surgery can be done under spinal anesthesia also. So as much as possible, we opt for the surgery. We also counsel in such a way that surgery should be their option. But there are a lot of families which do not opt for that at times. So I think, ultimately goes to the patient and bystanders on how they perceive it. But we usually, yes, we also ask for the surgery to be done. But very frail patients, sometimes nailing or something like that will be done. Very rarely, yes, just wait and all will be given.
Yeah, yes, madam. I am an orthopedician, but the thing is that the fracture anywhere in thigh or hip very painful. Even patient may not be, even elderly patient may not be able to sit on the bed. So to alleviate pain, better go for surgery.
Yes.
In a newer technique of anesthesia and other equipment, patient may escape anesthetic problems. But only thing is that problem of embolism, that is always there. Then it will be aggravated by cardiology medications. Nothing else. It is better advise surgery.
I know of a lady who was 92. So she had a fracture femur. I advised this, but they did not give fitness because she had a small coronary artery
That is possible in younger patients
problem,
having cardiac
but
problem.
finally what happened was she developed a sacral. Yes. So, and after some time, the pain was just like what you suggested. They had to go for an emergency surgery, and she lived till 97 and walked after the surgery.
Ma'am, there's a lot of ageism that happens, not just in the patients. I think it's also there amongst the healthcare providers, like the doctors itself. So whereby 92, the age itself sometimes prompts some people, oh no, that is too old. Why go for a surgery at this age? That is why this comprehensive geriatric assessment, assessing the functional status of the patient to actually know that, this patient is fit or not. There are actually clear guidelines to actually give fitness and all that, so which can be used. So I think as the ageism factor slowly comes down, that problem should gradually come down. In Amrita, per se, we do surgeries even in 90-year-olds and all that. We are doing surgeries right now.
Ma'am, I think it is always better to suggest surgery for the elderly patient. I'm an anesthetist. We are doing, I have done even in 94, at the age of 94 also we've done. And now newer modalities of anesthesia are there. Nerve blocks, ultrasound guided nerve blocks are there. So it's better to do surgery. And for the pain relief also, we can do some nerve blocks.
Early surgery improves the quality of life also.
Yeah, sure.
Definitely.
Yes.
Hip fracture surgery is what we always advocate for. But, when you come to elderly patients, there are some certain patients who are too frail to actually do anything. Yeah. So that is like a very minority, but those patients may not opt for surgeries. It is like some certain situations. I am not able to tell you like exact. Some patients who have been, it's usually due to pathological fractures rather than a fall and fracture that I'm talking about in those, that special conditions that I'm talking. Some are too frail, like you really can't do much in them. Such patients may not benefit from surgery. That spectrum also we have sometimes. Such patients, we go for palliation per se only.
Same goes for cataract also. Yeah, never, in spite of 1995, whatever be the age, they should always be encouraged to have cataract surgery.
Definitely.
Which will definitely improve the quality of life, not only of the patient, but also the caregiver.
Yes, definitely, yes.
What's your opinion about the catheterization of the elderly patient?
Catheterization is not something that should be done If there is a proper indication for catheterization, fine. But otherwise, as much as possible, it's better to avoid catheterization in the elderly. Did I answer your question, sir?
Yeah, thank you.
Do we sometimes have to catheterize patients to improve the quality of life of the caregiver?
Yes, sometimes, yes, we have to. But the thing is, usually when we have to do that, many times they have this recurrent urinary infections and all that, which again further burdens the caregivers in turn. But yes, there are situations that sometimes warrants that for the caregiver burden we might have to do. But as much as possible, we try to, counsel them, give them other options other than a proper catheterization, because catheterization per se makes them even more dependent. They will not be able to, generally elderly, they do not like tubes, and they do not like any tubes for that matter. So as much as possible, we try to discourage, but in some patients, depending on the situation, yes, we will have to.
I think mainly it is elderly female who is bedridden. The indwelling catheter request that comes because of the dampness in the perineal area causing further skin erosions and.
Yes.
The thing is, when you catheterize, the mobility is also will be restricted. Otherwise, they will move around.
What we usually try to do is at least to rehabilitate the patient to at least bed transfers. Like if we can at least transfer the patient from a bed to a commode, then we can do timely voiding during the day. So even before the patient actually says that the patient wants to void, we can ask the patient to just every 2 hourly or something, just make the patient sit on a commode, ask to void. And many patients are able to manage with that, and they have very less urinary leaks and all that, and at night they use a diaper, so that becomes okay as long as there's a caregiver who is available for that. Second thing, but if the patient is actually bed bound, then that becomes difficult. And if they are like even bed bound patients who are very thin built and all, who have good caregiver support, we are able to manage with this timely voiding and all that, toilet training basically. But for patients who are too hefty, or patients who are not able to be rehabilitated to that level, we might have to go for a catheter. Also, patients who are having an active bed sore and all that, we usually don't like to have them on a diaper and all that, because it can get the bed sore more infected. So in such patients, we definitely go for a catheterization.
I will treat the urge incontinence, ma'am. Urge incontinence in elderly. Should be treated. Or?
Yes, it can be treated definitely. But even in urge incontinence, one common lifestyle modification that we usually tell them is to not wait till they feel the urge. If they go to the washroom from time to time, they will not have the urge. They'll be able to manage that much better. But yes, there are also medicines that help with that.
What about foot care, self-foot care in elderly?
Self-foot care.
Yes, after 65, if any patient comes to me in OP, I will advise self-foot care, including exercise, inspection of their own foot, and wearing special shoes inside home and outside home to prevent injury. So it's all very important. You all people, I request you to look into the foot, maybe bunion or hammer toe, flat foot, then neurological problems, callus, cones, and everything. You have to teach them how to care their food.
Yeah, we don't advise all patients regarding food care, but definitely for those who have diabetes and all that, we usually tell them what all they can expect, what all they should look for, and then we tell them. Similarly, if patients are having neuropathic symptoms and we examine, we find that they have neuropathy, such patients are usually advised more than we don't usually give blanket advices. But yes, to those who are at risk of having food problems, definitely it is advisable to advise them regarding that as well.
Thank you, everyone. Thank you, Dr. Divya. I think it was a wonderful discussion today
Very good.
Thank you, sir.
and a very good
നമ്മുടെ ഈ
participation.
മൗദാനയില് ഡോക്ടർ ശശിധരന്റെ മകളാണോ?
അല്ല sir.
അല്ല.
So if there are no further more questions, then we can wrap up for today. Hope to see you all next Thursday. And as I had posted in the group, I have requested I have got few responses. So coming weeks, we are planning for people who have responded. We are planning to have a get together online to discuss on how, because as I said, നമ്മൾ ഇത് almost ഒരു 9 മാസമായി regular ആയിട്ട് പോകുന്നു. But ഇനി ഇത് 9 മാസം കൂടി പോയാൽ പോരാ, സ്ഥിരമായിട്ട് പോകണം, പാർട്ടിസിപ്പൻസ് കൂടണം. So how to bring in more innovative discussions, practical discussions to keep to that practical discussion aspect and bring more participants as well as presentation and more informative sessions like today. So we can think of taking it forward. So anyone who is again willing to volunteer in coordinating such things and having an academic group to take this forward, we are very much welcome. You can personally message me or put it in the group so that we can have a discussion in the coming days. So thank you, Dr. Divya. Thank you everyone for today's discussion.
Thank you,
Thank you.
IK and the palliative team for this wonderful opportunity.
Thank you, ma'am.
Thank you.
Thank you.